So after learning about the diagnostic criteria for bronchiectasis and the different causes and how do we evaluate for these causes, we will now study the treatment for bronchiectasis. So before proceeding with the different agents that we have for treating bronchiectasis, it is important for us to understand what is the goal of our therapy. So in bronchiectasis, there are predominantly three goals of therapy. The first goal is to reduce the symptom burden. So these patients are going to come to you with sputum production, with cough, with shortness of breath. So you have to give these patients agents which will help to improve their symptoms. The second important goal of therapy would be to treat the acute exacerbations. So one of the major problems would be that these patients on the background symptoms will be having acute episodic pneumonias or recurrent infections, and we have to give therapy for their acute episodes. And lastly is we have to give them therapy to prevent them from developing these recurrent episodes of exacerbations or pneumonias. So this will be predominantly our three goals of therapy, and then we'll have pharmacological therapy, that is use of drugs, and we'll have non-pharmacological therapy to address these goals. So firstly, let us look at the different agents that we have to reduce the symptom burden of these patients. So firstly, these patients can come to you with complaints of shortness of breath and wheezing. There is some obstruction happening in their airways, and therefore the use of bronchodilators like beta-2 agonists or muscarinic antagonists can be used to treat the shortness of breath and wheezing in these patients. So these patients can either be prescribed a SABA plus a SAMA during acute episodes of worsening, during the acute episodes. And if their spirometry is showing obstruction, the patient is complaining of wheezing and shortness of breath, they can be prescribed long-acting muscarinic antagonists and long-acting beta-2 agonists. So these bronchodilators in an inhaled form can be given to patients with bronchiectasis for symptomatic relief of shortness of breath. What is the role of inhaled corticosteroids? Then inhaled corticosteroids should not be given to all patients of bronchiectasis. Its use should be restricted to patients who either have ABPA or have a rheumatic disease as a cause for their bronchiectasis. The reason being, if patients with bronchiectasis are inadvertently prescribed ICS, then that can lead to an increased risk of pneumonia. So it should be avoided until and unless you have a specific reason for giving ICS. Now, the major problem of patients with bronchiectasis was mucus accumulation, which was thick, difficult to expectorate. So you have a class of drugs that are known as mucolytics. So what are mucolytics? Mucolytics are substances which will help to lyse the mucus and helps to liquefy the mucus and makes it more thin and makes it easy to expectorate. The common agents that you have is N-acetylcysteine. We also have agents like carbocysteine and erdocysteine. So these can come in oral tablets form, and sometimes they can also be nebulized, and they can help to liquefy the mucus and help in easy expectoration. And NAC has been shown to even reduce the risk of future exacerbations. Then, if you're not able to prescribe the patient mucolytics because of cost issues or availability issues, then patients can also be given hypertonic saline, that is 3% or 7% saline. How does hypertonic saline act? Is because of osmosis, water is going to move from a region of low osmolar content to a region of high osmolar content. So if in the lumen you have 3% saline, then water is going to move from the bronchial wall, from the cells into the lumen, and therefore the mucus that is present is going to be rich with water and it's going to get liquefied and will be easy to expectorate. So this is a relatively cheap way of making sure that the mucus in the patients of bronchiectasis is thin and is easy for them to expect it. So most of our patients of bronchiectasis in the OPD are actually prescribed nebulizations with saline and sometimes even hypertonic saline like 3%. And in patients with cystic fibrosis, sometimes in up to 7% of hypertonic saline can be prescribed. The important thing to know is that whenever you give the patient a mucolytic or you give the patient an hypertonic saline, so these agents themselves can lead to bronchospasm. So one of the common side effect of these agents is going to be bronchospasm. So therefore, before these agents are prescribed, before a mucolytic or inhaled mucolytic or hypertonic saline is prescribed, patients should be given some short-acting bronchodilators so as to overcome this side effect. So we give a SABA or a SAMA, and then the patients are given hypertonic saline or mucolytics. Apart from these treatment to reduce symptoms, then you can have etiology specific treatment. Depending on the cause of bronchiectasis, patients can be given different treatments. For example, patients with ABPA can be treated with oral steroids and antifungals. In the form of either itraconazole or voriconazole. The exact indications and the exact regimen of treatment will be discussed when we talk more about ABPA. For patients with cystic fibrosis, now we have cystic fibrosis specific treatment in the form of treatment that helps to potentiate the CFTR protein. This could be like agents like ivacaftor, tezacaftor. So we'll be discussing more in detail about these agents when we talk about cystic fibrosis. But just remember that now cystic fibrosis specific treatment is available and approved, although in India it is difficult to purchase and it is extremely expensive. For patients with CVID, that is patients who have extremely low immunoglobulin levels, immunoglobulin replacement therapy is given. Immunoglobulin therapy is given. So every 3 to 4 weeks, the patients are given IV injections which help to supplement their immunoglobulin levels, and the usual dose that we give is 400 mg per kg. So this can be given every 3 to 4 weeks, and our aim is to normalize the IgG level. So if that is done, then the bronchiectasis in these patients will not progress. The patients will not develop recurrent episodes of pneumonia. In patients with other primary immunodeficiencies, then accordingly treatment can be given, or the patients can be referred for bone marrow transplant. In patients with retroviral disease, you will start the patient on antiretroviral therapy. In patients with rheumatic disease like IBD and like rheumatoid arthritis, the treatment should be governed by the other important manifestations. For example, if a patient with rheumatoid arthritis has joint pains, their treatment should be focused on the joint pain, and similarly that treatment might also be effective for the bronchiectasis. For patients who are having active NTM and active tuberculosis, NTM treatment or anti-tubercular treatment should be prescribed. For patients with focal bronchiectasis who have bronchial obstruction and you are able to figure out that cause for obstruction, then therapy should be focused. For example, if there's a foreign body, we will remove the foreign body. If there's a tumor inside the bronchus, we'll try to remove the tumor either through surgery or through bronchoscopy. Then now there has been a new development. There has been a new drug that has recently come into existence that is known as brensocatib. So what is this drug? It's nothing but it's a DPP4 inhibitor. So DPP4 stands for dipeptidyl peptidase. So what does this drug do? This drug is actually inhibiting the proteases. So dipeptidyl peptidase is a peptidase. It's an enzyme that will break down proteins, and this drug inhibits this enzyme. Therefore, it prevents inflammation. It prevents inflammation, and by preventing inflammation, it can actually treat patients with bronchiectasis. It could be a disease modifying treatment. So the trial which looked at this drug was known as the Willow trial, which was a phase 2 trial. We are still awaiting results of larger phase 3 and phase 4 studies, after which this drug might be approved for treatment. But for now, there is this drug that we should know about, although it is not being prescribed because we don't have studies from phase 3 studies as of now. So after looking at the treatment for symptomatic management of bronchiectasis, the next goal of therapy was to treat the acute exacerbations, which are mostly infective. So how do we define an acute exacerbation of bronchiectasis? So to define it, the patient should have worsening of his symptoms. The patient should have worsening of the symptoms. And this worsening should be sufficient enough for the clinician to change the treatment of the patient or to prescribe antibiotics. So the definition involves two aspects. One, there should be a worsening of the symptoms, and that worsening should be sufficient enough to either prescribe antibiotics or to change the treatment regimen of the patient. So what are the common symptoms that can worsen or symptoms that are included in the definition? One, symptoms about sputum. So either the sputum becomes increasingly more purulent, or the quantity increases, or the consistency changes and becomes more thick, or the patients develop hemoptysis, the patients develop fever, or they might develop respiratory failure. So if the patient is having any of these symptoms and these symptoms are sufficient enough to warrant a change in the treatment or the prescription of antibiotics, then the patient is said to have an acute exacerbation of bronchiectasis. So most of these acute exacerbations are actually infective exacerbations, which is caused because of a new infection. So what are the risk factors for these acute exacerbations? What are the risk factors? The most important risk factor is actually a previous history of an exacerbation. This is similar to COPD. Like in COPD patients, the most important risk factor for a COPD exacerbation is the prior history of exacerbation. Similarly in bronchiectasis as well. Next would be presence of bacterial colonization, as we had seen. So patients who have bacterial colonization will exacerbate more frequently, especially if it is a Pseudomonas species. So now that the patient has come to you with an acute infective exacerbation, how do you treat it? Firstly, we need to know the duration of treatment. So in most cases of community acquired pneumonia, the current recommended duration of treatment is 5 to 7 days. Usually we stop the treatment after 5 days if the patient has shown clinical response. But in bronchiectasis patients, the treatment needs to be slightly more prolonged, and the optimal duration of treatment varies from 10 to 14 days. So 10 to 14 days of antibiotic treatment should be given to these patients. How do we select the antibiotic? So selection of antibiotic firstly will depend upon how symptomatic the patient is. If the patient comes to you with significant symptoms like class 4 dyspnea, comes to you with hypoxia or hypercapnia, and the patient is sick and he needs to be admitted to the hospital, then you give the patient IV antibiotics. Or if the patient just has mild worsening of his symptoms and can be managed on an outpatient basis, then you might want to give the patient oral antibiotics. So the first choice is between giving IV antibiotics or oral antibiotics. The second choice will depend upon the organism. If suppose the patient is having a Pseudomonas organism. So if the patient is having a Pseudomonas organism, then if we want to give oral antibiotics, usually we give the patient respiratory fluoroquinones like either ciprofloxacin. The common dosing can vary from 500 to 750 mg twice a day, and we give them to the patient for 10 to 14 days. If suppose a patient with Pseudomonas infection is sick enough and needs admission to the hospital, then the drug would be IV medications, either ceftazidime, or you can give the patient piperacillin tazobactam, or if these are not working, then the patient can also be prescribed carbapenems. If you have non-Pseudomonas species like Moraxella or Haemophilus influenzae or Moraxella, then for oral treatment, the patient can just be given a beta-lactam plus a beta-lactamase inhibitor. So in simple words, the patient can be given amoxicillin plus clavulanic acid or amoxiclav. And if the patient gets admitted, then patients can be given third generation cephalosporins. Or even simple injectable IV beta-lactams or penicillins. So the important thing to remember here is we should always investigate the patient for Pseudomonas. If that is present, then the therapy would be a respiratory fluoroquinolone, and the duration of therapy should be a bit longer, from 10 to 14 days, as opposed to a patient with community acquired pneumonia, where we usually give the treatment for 5 to 7 days. Now, apart from choosing the antibiotic, if the patient is actually coming with a Pseudomonas infection, which could either be a first infection at the first time the patient is having Pseudomonas, or a new isolate of Pseudomonas has been found when a bacterial culture was done. So in these patients, the treatment is slightly different apart from the choice of antibiotics. The reason is that it has been shown that patients who have a new Pseudomonas infection, in those patients, when we were giving the patients 2 weeks of antibiotics as recommended, be it IV or oral, then only 20% of these patients were having culture conversion. So this means that although these patients were symptomatically getting better with our IV or oral antibiotics, their culture was not getting converted, or Pseudomonas was not getting eradicated from their sputum. Only in 20% of the patients they were having a negative sputum, and 80% of the patients will actually go on to develop a chronic Pseudomonas colonization. And we have already seen that a chronic Pseudomonas colonization will lead to further episodes of pneumonia, will lead to further morbidity, and will increase the chance of mortality. Therefore, in patients who have developed a new onset Pseudomonas infection, just giving 2 weeks of antibiotic therapy is not going to help, and the prolonged course of antibiotics needs to be given. So how do we give a prolonged course of antibiotics? So studies were done which started looking at inhaled antibiotics. So they started looking at inhaled antibiotics. The most commonly used inhaled antibiotic which was shown to be efficacious was actually tobramycin. So it was shown in studies that a 3-month course of nebulized tobramycin in the dose of 300 milligrams twice a day actually improved the culture conversion from 20% to 55%. Right? So this became the standard of care. So now when a patient with bronchiectasis comes to you with a Pseudomonas infection that is new, the treatment is firstly you give the patient 2 weeks of therapy, which could be oral or IV depending on the patient's clinical scenario. This should be followed by 3 months of tobramycin therapy, and then a repeat culture should be done to assess for culture conversion. Right? So this is what this algorithm depicts. If a patient is having a new onset So you should remember this is a new onset Pseudomonas infection. Then if the patient is severely symptomatic, yes, the patient receives IV antibiotics. If the patient is mildly symptomatic, the patient receives oral antibiotics. And after that, the important thing is the patient should be given inhaled antibiotics like tobramycin for 3 months, and then a repeat assessment should be done. If the patient cannot be given tobramycin, what is the second alternative? The first choice is always tobramycin. The second alternative is the patient can be given inhaled colistin. One important practical thing to remember is that whenever you are prescribing the patient some form of an inhaled antibiotic, then prescribing the correct nebulizer is important. Different nebulizers are available, and the nebulizer that has the best deposition of antibiotics in the body is actually something known as a vibrating mesh nebulizer. So wherever antibiotics are prescribed, you should try to prescribe them using this specific nebulizer in order to increase the deposition of drug in the lungs. So after we have learned how to treat acute exacerbations, the next important goal of therapy was to prevent these acute episodes from happening. So how do we prevent recurrent exacerbations? So firstly, the most important thing to prevent recurrent exacerbations would be non-pharmacological treatment. Which will include a good bronchial hygiene. What do I mean by bronchial hygiene? The patient should do active and passive chest physiotherapy in order to ensure that he is able to expectorate or remove as much of phlegm, as much as mucus possible. Because the patient keeps on expectorating, keeps on exercising, then mucus will not accumulate, infections will not happen. The second important aspect would be vaccination and treatment of the underlying cause. So any patient who is having recurrent exacerbations, ensure that the patient is having a good bronchial hygiene, ensure that the patient is appropriately vaccinated, and ensure that the treatment of the underlying disease has been initiated and the patient is adherent and compliant to the treatment. If despite following these three things, the patient still continues to have recurrent exacerbations, then the most common reason is that the patient is going to have some form of bacterial colonization. So we need to focus on treating this bacterial colonizer. So what do the guidelines say is that if despite good bronchial hygiene, despite good vaccination, despite treatment of the underlying etiology, if a patient has greater than equal to 3 exacerbations in 1 year or greater than equal to 2 exacerbations in 6 months, or greater than equal to 1 severe exacerbation, in these patients we have to initiate pharmacological treatment to prevent these exacerbations. So if despite the above management the patient is having persistent exacerbations, we have to look for specific treatment to prevent this exacerbation. So the first step would be to do a sputum bacterial culture. So the sputum bacterial culture can show us 3 things. 1, it can show us Pseudomonas growth. It can show a non-Pseudomonas growth, or it can show no growth. So first let us talk about what if the culture starts showing Pseudomonas growth. So when the culture starts showing Pseudomonas growth, then it is advised that the patients should be prescribed long-term inhaled antibiotics. So the patient should be given long-term inhaled antibiotics. So what can be these antibiotics as we just saw? They could be tobramycin or they could be colistin. Other antibiotics that are available also are azthromycin, but the most common ones that are prescribed is going to be tobramycin or colistin. And when we prescribe these antibiotics for a long duration, in this we usually give a 1 month on and a 1 month off period. So therefore the patients are prescribed 1 month of nebulized antibiotics, then for 1 month they are kept off these antibiotics, then again the patients are prescribed 1 month antibiotics, and this goes on and so forth for years, right? So we are isolating Pseudomonas, the patient should be given long-term inhaled antibiotics. If suppose for some reason the patient cannot take long-term inhaled antibiotics, or the patient is not affording long-term inhaled antibiotics, the second option is to give the patient oral macrolide therapy. Oral macrolide therapy in the form of azithromycin. The dose is usually 250 mg per day or 500 mg every alternate day. So how does this work? Azithromycin, as we know, is an anti-inflammatory agent, and it will help to reduce the inflammation of the airways and not directly by destroying the bacteria. So this was about Pseudomonas. If suppose the patient shows non-Pseudomonas bacterial growth, some growth apart from Pseudomonas, then the first choice is to give the patient oral macrolide in the form of azithromycin. If for some reason the patient cannot take oral macrolide, then the second option is to give the patient long-term inhaled antibiotics. If the patient cannot take long-term inhaled antibiotics also, then the third option is to give the patient any other oral antibiotic to which the bacteria is sensitive. That is a targeted antibiotic. So if the patient is having a non-Pseudomonas infection, then first choice is to give a long-term oral macrolide, that is azithromycin. If it cannot be given, then you switch to a long-term and inhaled antibiotic or any other targeted oral antibiotic to which the bacteria is sensitive, which most commonly could be either like a respiratory phenocon like a Ciplox or Augmentin, that is amoxiclav, depending on whatever your culture sensitive report is. If the sputum culture does not show any growth, then you only have one option, that is to give the patient oral macrolide, that is azithromycin. So just briefly summarizing, if the patient is having recurrent exacerbations, that is more than 3 exacerbations in a year or more than 2 exacerbations in 6 months, we do a sputum bacterial culture. If the patient has Pseudomonas, we give the patient inhaled antibiotics. If the patient has non-Pseudomonas or there is no growth, then the treatment of choice is oral azithromycin. What if despite doing this, the patient still continues to have exacerbations? That is again equal to 3 or more in a year. Then it is suggested that you can combine the two treatment. You give a combined treatment. What does combined treatment mean? That you give the patient both inhaled antibiotics and you give the patient azithromycin or macrolide. Okay. If even after a combined treatment, the patient still has 5 or more exacerbations, then what is recommended is you can give the patient cyclical IV antibiotics. So what does cyclical IV antibiotics mean? It means that every 2 to 3 months, the patient is given one course of IV antibiotics to treat the infection. So this is how we follow. The first is giving one therapy. If one therapy is not working, you combine the therapy. If the combined therapy is not working and still there are more than 5 exacerbations, then you give cyclical IV antibiotics. So the same thing that we have discussed here can also be seen in this flowchart, which is given by the British Thoracic Society guidelines. This is the same thing which I have just simplified in the above diagram. So now that we have looked at the pharmacological aspects of treatment, we looked at how to reduce symptoms, how to treat the acute exacerbations, and how to treat or prevent recurrent exacerbations. Another very important aspect of treatment of bronchiectasis is non-pharmacological management. I cannot overemphasize the importance of this management because it is one of the most important things that will prevent your patients from deteriorating, that will help your patients to improve. And in your OPDs, you'll have to stress on this multiple times to ensure the patient is adherent and compliant to it. So non-pharmacological management, the most important component would be chest physiotherapy. So chest physiotherapy basically has 3 parts. First is tackling the mucus, or what is known as bronchial hygiene. That is to ensure that mucus is appropriately getting drained from the chest. The second part of chest physiotherapy would be building exercise capacity by active and passive limb training. Right? So the patient undergoes strength training as well as aerobic training, and this helps to build up exercise capacity. And the third part of chest physiotherapy would be building up the capacity of the inspiratory muscles, that is respiratory muscle training, also known as inspiratory muscle training or IMT, in which we are building the capacity of the diaphragm. So let us focus a bit more on how to tackle the mucus, or what are the different types of exercises that the patient can be prescribed in order to expectorate the mucus. So the most simple of them would be simple positioning, also known as postural drainage. So as the term suggests, by using different postures, we will improve the drainage of the bronchiectasis segments. For example, if the patient has an upper lobe predominant bronchiectasis, the patient can be made to bend forward, which will allow drainage of the bronchiectasis to be better. If the patient is having a left-sided bronchiectasis, the patient can be turned to a right lateral position, which will help drainage. If a patient is having a lower lobe predominant bronchiectasis, then patient can be put in a reverse Trendelenburg position with the head down and the foot end up, which will allow the drainage from the lower segments and will help in expectoration. So the simple technique would be postural drainage. Apart from postural drainage, there are other certain cuffing maneuvers that the patient can be taught, which include a huff puff maneuver, huff puff technique, and the second technique is known as ACBT. That stands for active cycle of breathing techniques. So these are maneuvers which you can learn from your chest physiotherapist. So you can just YouTube it and see how these maneuvers are done. This actually helps the patient to expectorate better from the distal to the proximal airways. Apart from simple exercise techniques, nowadays there are certain devices that can help the patient expectorate better. These devices are known as PEP devices. PEP devices. PEP stands for positive expiratory pressure. So this is an example. These are 2 devices that are available in the market. The first is the Aerobica device, and the second is the Acapella device. So the way these devices work is that the patient breathes into these devices during exhalation. So as the patient breathes into these devices have a flutter valve. They have a valve, and when the patient exhales, this valve vibrates, and this vibration of the valve makes the exhalation happen with slight resistance. This slight resistance leads to generation of some positive pressure, and along with this, the vibration of this flutter valve will send back vibrations into the patient's body. Vibrations or oscillations into the patient's body, and these oscillations will help to loosen the mucus from the airways, and as the mucus loosens from the airway walls, it becomes easy to expectorate. So this is what exactly is shown in this figure if you see closely. So this yellow represents the mucus, which is firmly adherent to the bronchial walls. When the patients start using these devices, it leads to generation of these vibrations. These vibrations will help to loosen the mucus, and then the patients are able to expectorate better. So these devices are known as PEP devices, aerobic and a cappella, and our patients who are having distal bronchiectasis can be prescribed such devices. They usually cost around 4,000 to 5,000 rupees and can be used for a prolonged period of time. Another device that is available in the market is the high frequency chest wall oscillator. That stands for HFCWO. So again, this is basically a vest that a child or an adult can wear, and then vibrations are sent through this vest, which leads to vibrations of the chest wall and helps to loosen the mucus and improves sputum production. So these are the devices that are available that can help to maintain a good bronchial hygiene. So now that you have taught the patient that he needs to use bronchodilators for symptomatic management, your patient also needs to use mucolytics or hypertonic saline for improving mucus drainage. The patient needs to exercise, do active physiotherapy to remove that mucus, and the patient might also be requiring inhaled antibiotics to prevent recurrent exacerbations. So what should be the appropriate sequence of using these medications to ensure that each of these medications are able to act properly? So the PTS guidelines gives us its recommendations, which are also logical. So it says that the first step should be using a short or a long acting bronchodilator, in which we use a beta 2 agonist or a muscarinic antagonist. The reason for giving this bronchodilator is to ensure the patients do not have bronchospasm and their bronchi are well dilated. It leads to bronchodilation. Step 2 is to use hypertonic saline or mucolytics. To use hypertonic saline or mucolytics. So as we know, hypertonic saline or mucolytics can lead to bronchospasm. Therefore, if we prescribe a bronchodilator before it, this side effect would be counteracted. So after you have given hypertonic saline or given mucolytics, then the patient should do active chest physiotherapy. So as the mucus is now loose, it's become more liquefied, then physiotherapy can help us expectorate the mucus. Now after physiotherapy is done, now that your airways are both dilated as well as your airways are now clear of any obstruction of any mucus, then the patient should be given inhaled antibiotics. So what do you want when you're giving the patient inhaled antibiotics? You want those antibiotics to reach the alveoli, right? So if your airway is obstructed with mucus or your airway is in spasm, there's no point of using these expensive medications. They're not going to reach where they're supposed to reach. Therefore, this is the sequence that should be followed. First, you give a bronchodilator, then you give a mucolytic or a hypertonic saline, then you ask the patient to do active physiotherapy, and after, when you're sure that your airways are now clear, then the patient should be given inhaled antibiotics like tobramycin or colistin. Apart from physiotherapy, the next important part of non-pharmacological management would be vaccination. Again, minimum what all vaccination should be given. The patient should be vaccinated for pneumococcal. Depending upon the age, you can either just prescribe a PPSV 23 or the patient would be requiring both a conjugate vaccine followed by a polysaccharide vaccine. Then the patient should be vaccinated for COVID-19. The patient should be vaccinated for influenza every year. The patient should be given pertussis vaccination if not given in childhood. Along with that, depending on the local guidelines, the patient can also be given vaccination for respiratory syncytial virus, that is RSV, and shingles. So this concludes our treatment for bronchiectasis. Just remember the goals of therapy, the pharmacological aspects, and don't forget the non-pharmacological aspects.